Welcome to the Brain Matters webinar. I'm Dick Moberg, your host for today's presentation. Our featured panelist is Dr. Ramon Diaz-Arrastia, who will be talking about the BOOST 3 trial. Instead of our normal industry partner, you'll hear from Dr. Ana Rodriguez on how we are involved in the BOOST trial. As usual, we will first review a few upcoming meetings and then get right into a recorded presentation, followed by a short presentation by Dr. Rodriguez. At the end, we'll have a live question and answer session from Dr. Diaz-Arrastia. And please type in your questions using the Q&A tab on your screen anytime during the presentation. Now let's look at some upcoming meetings. All of these meetings are listed in the events section on our website, www.moberg.com. As most of you know, this is medical meeting season with a lot going on over the next few months. Coming up, we have the ONE conference in San Diego that focuses on the nursing care of neonates with injured brains, followed by the neonatal brain monitoring meeting in Florida. Both are small and excellent meetings. Then we have the ACNS EEG meeting in Las Vegas. Next is the Society of Critical Care Medicine meeting in San Diego, and I suspect many of you will be there. Come by our booth as we are showing a lot of new features and we can talk further about any clinical trials you are planning. After SCCM, we have the Neurocritical Care Symposium in Philly, sponsored by Jefferson, and the Hypothermia meeting on the beach in Miami. And now a few abstract deadlines. Here are some deadlines. I won't read them all, but please check them out on the recording of this webinar, which will be on our website shortly following the presentation today. This is a good time to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. Your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. And finally, check out our website and newsletter for the next topic in Brain Matters. We plan to stay on a monthly schedule in 2019. If you have an idea for a topic, please contact us. So today's panelist is Dr. Ramon Diaz-Arrastia from the University of Pennsylvania. Several years ago, when I heard Ramon was coming to Penn from Washington, I was overjoyed, and I made sure I showed him my favorite Cuban restaurant and neighborhood bar. He's always been a mentor for me and a good friend as well. So without anything further, it's my honor to roll a video of his presentation, followed by a live Q&A.
Right, hello, I'm Ramon Diaz-Arrastia. I'm professor of neurology at the University of Pennsylvania, and I'm also scientific PI of the BOOST Phase 3 study, which will be launching in a couple of months. I moved here to the University of Pennsylvania in July of 2016, and that coincided with the institution creating the brand new Level 1 Trauma Center at Penn Presbyterian. And I've been very privileged to be able to recruit a terrific group of investigators, colleagues, clinical research coordinators to launch clinical TBI studies here at Penn. The University of Pennsylvania, as many of you know, has been among the leading institutions, if not the leading institution in the United States, studying traumatic brain injury since the 1970s. And I'm very pleased to be able to join it as of the last 2.5 years. All right, good afternoon. Thanks everybody for tuning in for this webinar on the brain oxygen optimization in severe TBI or BOOST trial. My name is Ramon Diaz-Arrastia. I'm professor of neurology at the University of Pennsylvania, and I have the privilege and honor of being the scientific PI for the BOOST study. So the question we've been faced with many times is, does improving cerebral oxygenation improve outcomes of a traumatic brain injury? And the answer is that we don't know. Although this is a technology that's been around for a long time, there remains a lot of equipoise. And frankly, the question belies the complexity of the answer. I think it is likely that in some cases, increasing cerebral oxygenation is in fact helpful, but probably not in others. And in fact, in some cases, in some situations, it may be harmful. We do know that cerebral blood flow and cerebral oxygen utilization is highly dynamic in critically ill patients. And the key is going to be delivering the right therapy at the right time to the right patients in order to really optimize outcomes. The disease that we are going after in trying to optimize cerebral oxygenation is microvascular injury. The brain is the most highly vascular organ in the body. The brain receives about 20% of the cardiac output, even though it constitutes only about 2% of the whole body weight. It is said that each neuron has its own personal capillary. And this preparation shows very nicely the capillary blood supply to the cerebral cortex, and it branches off, comes from these arterioles that branch off orthogonally from the Peel vessels that are running in the subarachnoid space. Now, because of the anatomy of these vessels, mechanical energy impacting the brain, and particularly when it results in shearing and inertial forces, has been recognized for a long time, as one can see here from this pathological specimen of a diffuse microvasculopathy that is present in the deep structures as well as in the superficial structures. And this has been well studied histopathologically as well. Here's an example from a very similar preparation as I showed you in the prior slide. This is a normal precapillary arteriole in an individual who died from a cause not related to brain injury. And as you can see, the vessel wall is nice and smooth. On the other hand, in a patient who died several days after a severe traumatic brain injury, as you can see, the vessel is very damaged. There are these thickening and folding and pits within the blood vessel wall. And histopathologically, this has been confirmed for many years by work from Dr. Stein here at the University of Pennsylvania, that there is a diffuse microvasculopathy that is present throughout the brain, not only proximal to visible contusions, but even present in areas where there is no grossly visible pathology. Dr. David Menon at Cambridge University has called this condition microcirculatory hypoxia to distinguish it from the more widely recognized macrocirculatory ischemia, such as occurs in stroke. In the normal situation, the blood entering the capillary bed is highly oxygenated, and there is a utilization of oxygen in the tissue, and therefore the blood exiting the capillary bed has a decrease in the oxygen content. In macrocirculatory ischemia, there is hypotension or stenosis of large vessels. There's reducing the amount of blood entering the capillaries, therefore the tissue extracts a higher fraction of oxygen from the blood. However, it remains ischemic. That's different from the situation that is common in traumatic brain injury, where you have a patchy microvascular collapse or occlusion of certain blood vessels. And what that does is it increases the gradient of it increases the distance that an oxygen molecule has to travel in the gas phase from the nearest capillary to get to the neuron. And that is the condition that this particular technology is going after. The ability to monitor brain tissue oxygen has been around for actually quite a long time. The Food and Drug Administration initially approved this technology, and this is the Lycox technology, in November of 2000, so it's been around for about 18 years. FDA approval of a device only requires that the device does what it is physiologically or from an engineering point of view advertised to do, and in fact it does measure the partial pressure of oxygen in brain tissue in the few millimeters right around the tip of the catheter. However, because there is no class 1 data that the use of this technology improves outcome, and this is a technology that is very labor intensive, the penetrance into utilization in neurological ICUs for the management of severe TBI has been very variable. It's widely used in some tertiary and quaternary academic medical centers, but even many highly experienced neurotrauma centers do not use this technology. Now, the rationale for monitoring in brain tissue oxygen and treating episodes of brain tissue hypoxia, likewise is well established. There is data, again, that has been around for a couple of decades, indicating that episodes of brain tissue hypoxia are very common. It's also well established that episodes of brain tissue hypoxia are associated with poor neurologic outcome, usually with pretty big effect sizes. I'll highlight a paper from our group many years ago that showed an odds ratio of almost 10 in favoring a unfavorable outcome or towards an unfavorable outcome in patients with severe TBI that had episodes of brain tissue hypoxia. Additionally, many interventions that are done on a daily basis routinely in neurological ICUs can rectify episodes of brain tissue hypoxia. And that includes administering normal baric hyperoxia. That includes augmenting cerebral perfusion pressure, either by administering fluids or administering pressors. That includes even things like transfusing red blood cells in patients who may have borderline anemia. There have been several non-randomized clinical trials that have been published over the last 10 years or so, suggesting that this technology may have some promise. And all of them find a odds ratio of somewhere around 2 favoring an improved outcome when patients are monitored and treated for episodes of brain tissue hypoxia. Now, because none of these studies were randomized, they had all used historical controls or concurrent controls by physician choice. They did not substantially improve practice. But those were the motivations for us conducting the BOOST-2 study. This is the phase 2 brain oxygen optimization in severe TBI, and that was the first randomized clinical trial of testing the utility of this technology. This study was done in 10 academic medical centers throughout the United States, all of whom were very experienced in traumatic brain injury. And the design of the study was to recruit patients who met the inclusion and exclusion criteria, which basically meant patients who had a severe enough TBI that they warranted invasive monitoring of their intracranial physiology. In most cases, that they would, according to the Brain Trauma Foundation guidelines, that they would require monitoring of intracranial pressure. Patients, after obtaining informed consent from the legally authorized representative, they were then randomized to a treatment protocol based on ICP monitoring alone, or a treatment protocol that was based on both intracranial pressure numbers and brain tissue oxygen numbers. Now, everybody had both an intracranial pressure monitor as well as a brain tissue oxygen monitor placed. However, in the group that was randomized to treatment that was based only on ICP monitoring, the brain tissue oxygen number was masked, and the treatment staff and their treatment decisions were based only on the pressure number. Interventions were triggered either by intracranial hypertension or by intracranial hypoxia, or in some cases a combination of both. The monitoring went on for approximately 5 days, and outcome was obtained by telephone 6 months after injury using the Glasgow Outcome Scale Extended. The primary and secondary objectives of the BOOST-2 study were as follows. The primary objective was physiologic efficacy, meaning that a treatment protocol informed by brain tissue oxygen monitoring numbers would in fact reduce the prevalence of brain tissue hypoxia. We felt that this was important to demonstrate the effect of the therapy on the biomarker before we were ready to go on to a definitive phase 3 study. We had a number of secondary objectives. We wanted to demonstrate safety, that adverse events associated with brain tissue oxygen monitoring and the treatment protocol based on brain tissue oxygen monitoring were relatively rare. We wanted to demonstrate feasibility. This was a complicated study in multiple centers using complex technology. We wanted to demonstrate that well-trained and experienced neurological intensive care units could in fact respond to episodes of brain tissue hypoxia and institute a complex treatment protocol comparably and reliably. And finally, we also had a non-futility hypothesis. And although the study was not powered to show a definitive clinical benefit, it was powered to meet the non-futility hypothesis, meaning that we had to show that there was at least a trend towards a favorable benefit and that futility was excluded. And this is the way that this is statistically dealt with. We ended up enrolling about 119 patients, as you can see in the demographic table. They were in their late 30s. They were predominantly male, as expected, given the epidemiology of traumatic brain injury. And these were almost exclusively closed head injuries, mostly from motor vehicle accidents. And they all had severe TBI. As you can see, the mean Glasgow Coma score was just south of 4. And this is what the primary data from the study looked like. Brain tissue oxygen was monitored continuously. And as you can see, it is a highly dynamic measure. There are these oscillations that are apparent if you monitor continuously. And the primary outcomes of the study was based on two things. It was based on the total amount of time in these red bars where the brain tissue oxygen value dipped below 20 millimeters of mercury. And also it was based on the area over the curve, as it were, in these yellow regions, mainly the product of the time and also the depth of which the brain tissue oxygen number fell. And we labeled episodes, and these were, in fact, what needed to be treated. So the primary outcome of the study was highly positive. In fact, the study was stopped early by the DSMB because of early efficacy. In the group where a treatment protocol was targeting only intracranial pressure, where the brain tissue oxygen number was blind to the treating staff, approximately 45% of the time, the brain tissue oxygen number was below 20 millimeters of mercury, and that was only 16% of the time if the treating staff was aware of the oxygen number and was treating the oxygen number. That was true whether one considered the proportion of the time below 20 milliliters of mercury, the average amount below 20 milliliters of mercury, or also the area over the curve, all highly statistically significant. And this is what the cumulative distribution looked like. There are approximately 10 to 15% of patients who never got into trouble with intracranial hypoxia. And as you can see, if we were in fact treating the brain tissue oxygen number, we greatly reduced the cumulative amount of time and the total hypoxia burden that these individuals were experiencing. Now, as expected, there was no difference in the intracranial pressure metric. In both groups, intracranial pressure was being treated, and in both groups, only about 15% of the time or so was there intracranial hypertension, and that was equivalent between the two groups, and the cumulative distribution curves, as you can see, were totally superimposed one upon the other. So we were gratified that at least in terms of our primary hypothesis of physiologic efficacy, the study was highly positive. In terms of the secondary hypothesis, I think we were gratified that the frequency of serious adverse events was no different between the two groups. We were particularly concerned that respiratory serious adverse events would be higher in the group that were receiving brain tissue oxygen directed therapies, because many of these brain tissue oxygen directed therapies could be toxic to the lungs. And there were a few more serious adverse events respiratory SAEs in that group, but this was not statistically significant, and overall the number of SAEs was low. The study, although there were certain challenges in terms of implementation of the study, the number of protocol deviations and violations were relatively low, and they were comparable between the two groups as well. And this is something that it will be a challenge as we go forward with the phase 3 study that will utilize a larger number of sites. And finally, we were very excited to see that the non-futility hypothesis was also achieved, namely that there was a trend, and the trend met the pre-specified statistical criteria towards a clinical benefit in the group that whose treatment protocol was based both on intracranial pressure as well as brain tissue oxygen. In the group that was being treated for ICP only, there were approximately 34% deaths, and that was only 25% in the group where the brain tissue oxygen was being treated. And this was not associated with an increase in other poor outcome categories, but it was actually associated with an increase in favorable outcome, meaning either total recovery or minor disability, GOSE 8 or 7. And that was true whether or not one used the GOSE or the disability rating scale at 6 months. So again, this did not reach statistical significance in proving that there was a clinical benefit, but it showed that there was a trend towards the clinical benefit, which met these pre-specified non-futility hypothesis. So based on the very favorable results of the BOOST-2 study, we designed the BOOST phase 3 study, and this study is being launched within the next few months, and it's being done in collaboration with the NIH Siren Emergency Trials Network at the University of Michigan. Dr. Bill Barson, who is the principal investigator for the Clinical Coordinating Center of Siren, is the contact PI for BOOST-3. I am the scientific PI, and I'm very privileged to be working with Lori Shutter, who's a neurointensivist and the clinical PI of the study, as well as Sharon Yates, who is the PI of the Siren Data Coordinating Center at the Medical University of South Carolina. BOOST Phase 3 was approved by the NANDS Council. The target enrollment is going to be somewhat over 1,000 patients, and that is powered to detect a 10% absolute improvement in good outcome using the Glasgow Outcome Scale Extended as the primary outcome measure, but analyzed using a sliding dichotomy approach. We anticipated we're going to need 45 sites to do the study, and as I mentioned, this is going to be done in collaboration with the Siren Network. And the treatment strategy will be based on what particular pathology and what particular physiology is going on at a patient at any given time. Treatments are going to be targeted at epochs, whether the problem is one of isolated intracranial hypertension, of isolated intracranial hypoxia, or whether there's a combination of intracranial hypertension and intracranial hypoxia. And this is a complicated slide. I don't expect everybody to be able to read it, but the treatment strategies are based on expert opinion. These are strategies that are used on a daily basis in neurological intensive care units to manage patients with severe TBI. And they were arranged in tiers. Tier 1 therapies are the less invasive and the initial treatments that one would institute. And these are then followed by Tier 2 therapies that are somewhat more invasive, also somewhat higher risk. And then Tier 3 therapies are things like decompressive craniectomy and pentobarbital coma. And these are optional therapies only. And this is a way that we can monitor what therapies were actually instituted in each of the groups. Summarizing the differences between the Phase 2 BOOST study and the Phase 3 study, obviously the primary difference is the primary outcome. BOOST 2 was designed to demonstrate physiologic efficacy, and it showed that very clearly. BOOST 3, a larger study, it's designed to demonstrate clinical efficacy, meaning that success will be determined if we can actually improve neurologic outcomes at a statistically significant level. The time window for enrollment is also going to be somewhat different. In the phase 2 study, we enrolled within 12 hours of injury. In the phase 3 study, we believe that this treatment is most effective is started early, and therefore the time window is going to be within 6 hours of arrival at the treating hospital and no more than 12 hours from injury. And we believe that a well-functioning neurological ICU and a well-functioning neurotrauma center should be able to start this therapy within 6 hours of arrival at the treating hospital. We changed the ICP threshold slightly from 20 to 22 based on the new Brain Trauma Foundation guidelines, and obviously we're going to spend a lot more effort in training and monitoring and clinical standardization, given that we're going from 10 sites to 45 sites. The primary outcome is going to be analyzed based on a sliding dichotomy, and this is a way to improve power and gets maximal information available from every patient. And basically that means that if patients had a prior probability of doing pretty well, we will call it a win only if they scored a GOSC of 7 or 8. On the other hand, if they had a prior probability of being in greater danger of a poor outcome, we will score it a win at lower levels of recovery. In conclusion, I hope I have told you, I've shown you that a treatment protocol informed by both brain tissue oxygen and intracranial pressure measurements reduces the duration of brain tissue hypoxia. This treatment protocol is feasible with modest number of protocol deviations and violations, and that it is consistent with a reduction in mortality and increase in good recovery. And based on this data, we're very excited that we're going to be starting the definitive phase 3 trial in 2019. And again, thank you much for your attention, and I think we have time for some questions.
Thank you very much, Ramon. Please get your questions ready for the live session. Use the Q&A tab on your screen. And while you're doing that, Dr. Rodriguez will provide a brief overview of our involvement in clinical trials, including BOOST.
Hi, I'm Ana Rodriguez, Director of Research at Moberg ICU Solutions. Since Moberg's early days, we've always been proud to support the needs of the research community, and our involvement in clinical trials is a natural consequence of the CNS monitor being a data aggregator designed to be used at the bedside and with embedded instructional material and annotation features. One of the first studies we were involved in focused on the use of amplitude integrated EEG during hypothermia in infants with hypoxic ischemic encephalopathy, and it was followed by BOOST 2. We then became involved in Track TBI here in the US and in Center TBI in Europe. We are currently involved in the SD2 study on spreading the polarizations, and we are supporting the launch of BOOST 3. For the upcoming BOOST 3 study, we are developing CarePath, which is an application designed to promote study protocol compliance and to encourage the annotating of data. We're also working closely with IBM to offer BOOST 3 data monitoring and biostatistical groups, cloud-based tools to facilitate data sharing across sites and to support the prototyping of advanced data analysis algorithms. Overall, Moberg can provide valuable guidance in the early planning and launching phase of your trial. We offer a streamlined solution for collection of high-resolution data, and we have demonstrated a continued commitment towards the development of standards for measurement nomenclature, annotations, and data archiving, all vital aspects of successful clinical trials.
Thank you, Anna. So once again, please send in your questions. We'll now go live to Dr. Diaz-Arrastia for our Q&A session.
Hi, we have some very interesting questions already. There's a question, very common question that we get from a lot of people, from Dr. Andrei Osharov. Where will we localize the brain tissue oxygen sensor? in patients with diffuse or focal TBI. The answer to that is that most patients with severe TBI have both diffuse and focal pathology. And in fact, it's the diffuse pathology that most likely drives the disability, and the microvascular injury, which is the pathology that we're primarily targeting here, is very commonly diffuse, and in fact, that's the primary pathology we're going after. The only practical way to do this is to insert the probe in normal appearing cortex. It's very difficult to target the penumbral area. That was an attempt using this technology early on. That's actually very difficult to do. It may be doable in cases that require a craniectomy or in the operating room, but even there you often miss it, and obviously the probe is not informative if you put it in the middle of the contusion. And you know, the whole concept of penumbra can be remains, I think, somewhat controversial in TBI. It's a concept that is developed mainly from the stroke world, and it does not translate very well to TBI. So the short answer is that we are going to be placing the probes in normal appearing cortex, in most cases in the right frontal lobe, if there is no visible contusion there, and if there is a visible contusion there, try and put it on the left side or somewhere far away from the contusion. And although we realize that the number that we get from the brain tissue oxygen sensor is a highly focal number, we are going to be interpreting that as giving us a global number, and that's what the physiology is based at. Okay. Second question is from Dr. Chris Robinson at the University of Florida. I often find trauma physicians question the treatment algorithm of cerebral hypoxia stemming from the known physiologic principles of oxygen content, meaning that increasing FiO2 should not have a large impact on oxygenation. I think that's obviously a question we get all the time as well. And the answer is that increasing FiO2 shouldn't be the only or even perhaps the primary method. I think what does happen with brain injury is that there is this diffuse microthrombosis throughout the brain, and thus the brain, because of its high oxygen demand, is going to be less tolerant to minor degrees of hypoxia than the visceral organs, right? So it may well be that maintaining a PaO2 of 65 to 70 is perfectly okay for the heart and the liver and the guts, but if the brain tissue oxygen falls below 20, that may be a patient where the PaO2 may need to be 90 or 100 or even 110 or 120. Certainly increasing the PaO2 beyond that is unlikely to be very helpful, because it certainly doesn't increase the oxygen content a great deal beyond that. I think the other issue, which I tried to address early in the talk when I presented the difference between macrocirculatory ischemia and microcirculatory hypoxia, is that when you're dealing with a diffusion hypoxia, that is a greater, when the distance between the nearest capillary and the neuron is increased, as is the case in TBI, that diffusion has to happen in the gas phase. So again, that's a rationale for why in TBI you may want a PaO2 to be higher than you would need for the management of other organs. Next question. And Dick, is there a possibility for follow-up questions from these folks, or how does that work out?
If they can type them in.
If they can type them in. Okay, good. So let me go on to the next question. So the question was, the 6 or 12 hours is for randomization of monitor placement. It's for randomization, and we anticipate that most of the time the randomization will be occurring simultaneous to monitor placement. Monitor placement typically takes 15, 20, 30 minutes, right, for the whole procedure to be done, and during that time the randomization will be done. So at the time the monitors are in place and ready to be hooked up, we will know whether that's a patient who needs to be in the oxygen blinded arm or not. So that's hopefully that's clear enough for there. There may well be some cases in which maybe the patient needs to be taken care of emergently to the operating room during the time of randomization, in which time the hooking up of the monitor may be at some later point, but we expect that to be the minority of the times. So the next question down the line from Dr. Zhou, any protocolized placement of the Lycox monitor? And yeah, we're following here the standard approach that is widely used for placing Lycox monitors. Most of the time, this is going to be done through a bolt, and it likely will be the same multi-lumen bolt through which the pressure monitor is placed. But occasionally, in people who may require a craniectomy, the probe may be placed in the operating room and will be tunneled under the skin, and that's perfectly okay as well. That obviously is going to depend. There are going to be some variability from patient to patient. Next question from Dr. Hicks. Are the other protocols standardized, or will the variability of treatments hide the benefits? And I think this is a very, very important question, something we've grappled with from the very beginning of the design of the phase 2 study. And the approach that we have taken, Mona, as well as others who are wondering about the same thing, is that we want to standardize the protocol as much as is practical. On the other hand, much of the treatments for this are not supported by good data. Certainly, there's very little class 1 data or even class 2 data that supports one or another treatment protocol. We did not want to be in a position of having to write a textbook of neurocritical care as part of our treatment protocol. And we wanted to rely on the expertise of the neurointensivists at each site to help guide the complex decisions as to what may be the most appropriate management. And I think the other reason why we felt this approach was what was important to use is that we certainly want this technology, if the study is positive, to be readily disseminatable or be readily adopted by neurotrauma units throughout the country and really throughout the world. So we wanted to have the protocol be pragmatic and practical, and we did not want to get into very potentially contentious debates when the data just really wasn't there. And at the end of the day, I think Mona raises an important point. Will the noise in the variability of treatments hide the benefits? And my answer to that is that if the benefit is small enough that it is lost in the noise and in the center to center variability, which we all appreciate is significant, it's probably not a benefit that is going to change practice and at the end of the day be widely disseminatable. That was kind of the choice we made in the design of the study, and it's clearly what we're going to have to go with. The next question from Dr. Chen is, how does the center become involved with Boost 3? We have been working hard over the past 9 to 12 months, really, in selecting sites for Boost 3. We have identified 45 sites in North America that will be involved in this. We may well need some backup sites. I think our estimate that we would average half a patient enrolled per month per site, meaning that on average sites will enroll 6 patients a year, will get us where we need to be in about 3.5 years. If we fall significantly below that target rate of enrollment, we will definitely have to recruit new sites. So I would encourage you, sites that have the expertise in brain tissue oxygen monitoring and may be interested as being put on the list as backup sites, to certainly contact me or contact Dr. Shutter or Dr. Barson at the Siren Clinical Coordinating Center. We have some sites on the backup list already, and I think it's very likely that we will need to go to recruit some of those, given the universal problem in these kinds of studies, which is always recruitment rate and recruitment. Going further, another question from Dr. Hicks. Do you have concerns that people will not want to be in the control group given the known physiological benefits? And this was actually a very big concern for us, certainly in the design of the BOOST-2 study. And in the BOOST-2 study, we had to obtain written consent from the legally authorized representatives. That was not done under EFIC guidelines. And that was a concern. We had to tell people, we're going to put these 2 probes into your loved one, but there's a 50-50 chance that we may blind one number. Surprisingly, it actually wasn't that hard, because we really did explain to people that we had equipoise, that we really did not know whether the treatments informed or the treatments guided by the brain tissue oxygen number were going to result in a benefit. And in fact, it was entirely possible that the numbers, would result in harm. And many patients or many families that I personally consented, I would tell them the story that, when I was a neurology resident back in the 80s, when we were treating intracranial hypertension, and back then it was very common to treat elevated ICP with hyperventilation. And that's before we realized that we were, in fact, probably causing ischemia and making people worse by treating this number. So most people eventually understood. I think this is a concern, but I believe that most people will eventually understand if presented to it the right way. I mean, there truly is equipoise throughout the neurotrauma community and the neurocritical care community, which is the reason why this technology is not widely utilized. Next question from Dr. Chen. Is the oxygen probe limited to LACOX or the Raumedic also included? And the answer is that Raumedics is included, and we certainly will allow either LACOX or Raumedics as a treatment strategy, again, with the long-term goal in mind that if this study is positive, that we will be able to widely disseminate the use of this technology, and that it would be widely adopted. So we did not want to make it specific to any one particular manufacturer of the devices. All right, next question from Dr. Ali. Can I get my center involved in Boost 3? I think we have already kind of talked that question. Unfortunately, we for many reasons, we are limiting this study to North American sites. We do have a few Canadian sites. The vast majority of them are in the United States. So we don't currently have the ability to recruit sites in India or really outside of North America. And that's the situation we're in right now. Let's see, another question from Dr. Zhou. Many years ago, a perfusion microdialysis study from UCLA suggested that there's a lot of disability driven by non-ischemic metabolic crisis due to mitochondrial failure. How might this affect the traumatized brain's ability to utilize oxygen? I think this is a very important issue, and in fact, that study from Dr. Vespa's group did indicate, as I recall it, that there was a decline in brain tissue oxygen associated with these metabolic crises, although it didn't meet the full criteria for ischemia, that it was related to that. And I think at the end of the day, and I think it's very important to know this, I mean, there are multiple pathologies that occur after traumatic brain injury. There is axonal stretching and axonal shearing. There is inflammation. There's obviously the focal contusions. This technology is really focused on the microvascular traumatic microvascular injury and this microvascular thrombosis that I mentioned about in the first two slides. So we're not going to fix all of TBI. We're fully aware of that. On the other hand, we do believe that this microvascular pathology is an important driver of disability and ultimately poor outcome. And that's the rationale for doing the study. But at the end of the day, I mean, this is not going to be the final answer in the management of TBI. I suspect that once we really learn how to manage TBI, this will be part of the solution. But there's certainly going to be lots of room to use other approaches, and there's certainly a lot of area here for research. Let's see, one more question from an anonymous attendee. Is there data correlating or comparing white matter oxygen consumption versus gray matter oxygen consumption? Is one more clinically important than the other? I think that is a really important question from the basic science point of view. There is some data, but really not very much. I would refer to you to really work being done at Cambridge University by Dr. David Menon and his group. They have a very unique capabilities there at Cambridge in that they have a PET scanner and a cyclotron adjacent to their neuro ICU. So they can do studies using oxygen 15 PET and oxygen 15 water PET. And so they can measure things like the cerebral metabolic rate of oxygen using PET in a regional basis. That's a very unique capability, and they published some very important studies on that. And it's likely that they're both important. Obviously, the oxygen consumption in the gray matter is higher than for white matter, and they're probably certainly both affected. I hope that was a sufficient answer to that very important question. All right, next question from Dr. Carolina Maciel. Would you consider spreading depolarizations, which are common in severe TBI, as a potential etiology for low brain tissue oxygen? And that's a very important question. And in fact, I see the next question is from Dr. Hardings, who's probably in an even better position than I to answer this question. And I think it is likely that at least some of the these oscillations in brain tissue oxygen that are found are a consequence of spreading depolarizations, which we're not necessarily detecting or directly treating in this particular study. So, are there any plans for a priori subgroup analysis for groups that are receiving ST modulating drugs? And the answer is no. We do have to limit the number of a priori analyses that we're going to be doing, and this is not one of the ones that is planned. We are going to be capturing all the drugs that are used in this population, so I would think that would be an attractive secondary or tertiary analysis to be done down the line, and I would certainly be very supportive of it. Next question from Dr. Hardings, who probably should answer the prior question on the cortical spreading depolarizations. He asks, it would be interesting to perform a pre-planned subgroup analysis based on sites ranked by level of neurointensive care service. Such data ranking exists. This would address concerns about uncontrolled variability in treatments and care. It might also help understand why trials tend to fail when expanded to phase 3 to a massive number of sites. So this is a really important question, and we are going to, there is a pre-planned analysis using center as a variable. So we will, we will, and again, I'm not a statistician, and perhaps Dr. Temkin or Dr. Sharon Yates, who are the biostatisticians for Boost, would be in a better position to answer this. But the answer is that's a really important point. There clearly are center-to-center differences. We are going to be analyzing the data, taking into account the center-to-center differences, and there will be randomization, and center will be one of the variables involved in the randomization. I believe so anyway. The other question that Jed asks is whether data exists or rankings exist in neuro-ICUs, and I'm not aware of any rankings by neuro-ICUs, and to be honest, even if there is any data, so sort of as would be useful for comparative effectiveness type research, I know there's an effort in the Severe TBI group to obtain that kind of information, meaning just to look at practice patterns between different neurotrauma ICUs, such as staffing ratios or use of equipment or things like that. That was one of the goals of the Track TBI effort in the United States as well. I think that's an effort that is still ongoing, but it's a very important question, and it's probably one that we could do a better job of, and likely would be an attractive pattern for an attractive tertiary analysis. The final question, can you explain the EFIC process? So this is a very important issue. So EFIC stands for Exemption from Informed Consent, and this is an option that is allowed by the FDA, and it's allowed by the governing ethics of clinical research in the United States. And this is relevant for emergency research in life-threatening conditions where there is a potential benefit to the patient. So in research where starting the treatment in a very rapid fashion is of the essence, where the patient, by the nature of the disease, is not able to provide consent themselves, and where difficulties or challenges in finding a legally authorized representative in a timely fashion would make the research not practical. The FDA and the regulatory agencies in the United States allow for the use of EFIC. What EFIC means, the requirements for EFIC is that the investigators have to do community consultation before they start the study, meaning that they have to go out to community groups, and that includes groups in the general community. It includes groups of patients who are TBI survivors. It potentially includes groups of people who are at risk for TBI, such as motorcycle clubs or things like that, and explain to them what the study is, and explain to them what the study is, and get their input into the study, and also give the option for people who attend these community outreach to opt out, and that can be either including a bracelet that they would wear to say, I'm opting out of this study. That's very rare, but the guidelines for EFIC require that the option for opting out be provided. There's several studies that have been done under EFIC over the last 10 to 15 years in the United States. The PROTECT study, which was a TBI study done also through the what used to be the NET network, is now a CIRE network, was done under EFIC. There are other emergency medicine trials in critical conditions that have been done under EFIC as well. And it's an important thing. We anticipate that in roughly 50% of our patients, we will not be able to find the legally authorized representative, and we will have to enroll them under EFIC. The EFIC guidelines also allow that once the family is located, that they have the option to opt out. That likewise is one of the guidelines there as well. So I hope that answers that question. We have one more question. If I do not want my loved one to participate in the study, is there an opt-out option available? And the answer is yes. And that is part of the EFIC requirements, and that is included in the, each site will have a somewhat different mechanism. We have options for that. That includes everything from having your name placed in a national opt-out registry, which we have to check before we enroll someone under EFIC. That includes things like wearing a bracelet to indicate that you're opting out of this particular study. So those options do exist. Final question, or at least the final question so far. Are the protocols for corrections of PbtO2 the same in Boost 2 as in Boost 3? And the answer is that they're very similar, but not exactly the same. There have been some additional discussions and some refinements based on evolving expert opinion, and also somewhat on the findings from Boost 2. So they're roughly very similar, but there are some minor changes here and there that have been made in the protocol. So Dick, I think we have gone through all the questions.
Yeah, that's great. Thank you. There are 2 questions that came in through the chat window, and I don't know if you want to open that. My sense is you covered both of these.
Let me open up the chat window here.
Yeah, I think you've covered them, but maybe you want to acknowledge them.
All right, let me see here if I can do that. Okay. There's a question from Anita Fetzik. Will Boost 3 have an emergency waiver of consent? And it will have this EFIC procedure, right, of exemption from informed consent. So it's not a waiver, it's an exemption. I think the differences are pretty minor. Question is, will allow study centers in Europe? And I think the answer there is that we considered that. But as of right now, we're just going with North American centers. If it turns out that we're having challenges with enrolling in the United States and the Canadian sites we have, we may need to expand to sites outside of North America. But for now, our plans are to focus our sites in North America.
Well, I think that's it. Unless there are any more questions you see on your end.
I think that was it.
Okay, well, thank you so much for your presentation. You actually broke a viewer attendance record, which is a testament to the excitement of this trial. So thanks again, Ramon, and appreciate your participation. And I'm going to go to our last slide, and thank you all for joining us, all the participants. And special thanks to those connecting from Europe. I know there's quite a few of you, very late on a Friday night. We appreciate that. And we hope to see all of you on our next webinar. So thanks very much for joining us.
All right, thanks so much, Dick, for setting us up.